Hello and welcome to Putting Evidence into Practice, Data to Inform Successful Family Planning Programming. I'm Rebecca Shore, Program Manager for the Measurement, Learning, and Evaluation for the Urban Reproductive Health Initiative, or the MLE project, based here at Johns Hopkins Center for Communication Programs. Today we'll be going through a presentation, so I just want to go over some quick logistics before I introduce our presenter. All participants will be in listen-only mode for the duration of the webinar. If you have questions, please use the chat box and I'll be monitoring that throughout the presentation. Presentation will last about 40 to 45 minutes and then we'll have time for a few questions. I'll go through the questions and share some of them with our presenter. Whatever questions we don't get to, we'll send out answers to all of you after the webinar. So I'd like to introduce our presenter today. His name is Peter M. Lance, PhD. He's an economist at the University of North Carolina at Chapel Hill. He's responsible for developing the quantitative design, overseeing information collection for quantitative components, estimating impact, and producing reports. Dr. Lance earned his PhD in economics from the University of North Carolina at Chapel Hill with a focus on health, econometrics, and economic development. Since earning his PhD, Dr. Lance's work has focused on program impact evaluation, modeling of health behaviors and outcomes, and survey sampling. He has served as a sampling expert and analyst at all phases of many surveys. His work has involved China, India, Thailand, Bangladesh, Nigeria, Senegal, Kenya, and Indonesia. He works on several different projects, including serving as a senior statistician on the MLE project, which he'll be presenting on today. Peter? Hold on one sec. Okay, go ahead, Peter.
Okay, well, so good morning, and thank you for joining me today for this webinar to discuss the Measurement, Learning, and Evaluation, or MLE, project's design, findings, and lessons. I'm joined here in the studio, so to speak, by my colleagues on this project, Lisa Calhoun and Amy Benson. And this is a presentation that I originally developed with another colleague on the project, Eileen Spitzer. Okay, so I'm sorry, my PowerPoint's a little sticky, so slide transition might be a little choppy occasionally this morning. So to get some sense of the context for this project, we're going to talk about today. You have to go back to the mid-late 2000s, which was a time when the Bill and Melinda Gates Foundation looked around the world and they recognized that the urban environment was becoming a critical focus area in terms of the global family planning agenda. They responded to this by creating the Urban Reproductive Health Initiative, or URHI, which, as its name suggests, was designed to focus on reproductive health in the urban arena. The specific objectives of the URHI included integrating family planning with mother and newborn child health and reproductive health services, routine health services, improving the quality of family planning services, promoting public-private partnerships, promoting demand generation or generating demand for family planning, and advocacy. The decision was quickly made that the URHI would occur in select cities in a few countries. These included cities in Senegal, Nigeria, Kenya, and India, specifically cities in the Uttar Pradesh state of India. In each country, the URHI was designed and run by a different local implementing partner. For instance, in Nigeria, the Nigerian Urban Reproductive Health Initiative, or NURI, designed the local implementation of the URHI. Part of the reason for a focus on several specific diverse societies was that from the outset, the Bill and Melinda Gates Foundation viewed the URHI as a laboratory for learning what works and what doesn't in promoting family planning use in the urban environment. In other words, they wanted to know what URHI program components worked best to promote family planning among the urban populations they sought to serve. They wanted evidence-based programming. Toward that end, they created the Measurement, Learning, and Evaluation, or MLE project, as an independent monitoring and evaluation arm for the URHI. The MLE project's objectives are: 1, to monitor and evaluate the impact of the URHI, 2, to build country and regional research and evaluation capacity, and 3, to facilitate knowledge sharing and document and disseminate best practices. Today's discussion is going to focus on MLE's work under Objective 1. The Two key evaluation questions for the MLE project are, well, did the project increase modern contraception prevalence, and what happened with the poor? Owing to time constraints, our focus is going to be on one, the overall impact on modern CPR, our focus today. So now let's turn to the data design behind the evaluation results. The cornerstone of this was longitudinal surveys of women in study cities. In other words, we interviewed a sample of women at repeated points over time. This data design is a real pain to collect, but there is an immense payoff in terms of stronger evaluation results. At the same time longitudinal interviews were being conducted, we also surveyed local facilities. This allowed us to capture the local supply environment for family planning and, crucially, the fruits of URHI efforts aimed at improving the supply side. In terms of specific timing, we collected 3 waves of longitudinal data. First, there was a baseline before program operations began. Henceforth, for the purposes of our discussion today, we will refer to the baseline as having occurred at time t equals 0, where t is a variable that means time. This was followed by a midterm designed to provide crucial mid-course information, and finally an end line. We will refer to the end line as having occurred at time t equals 1. Let's think about what we would observe in terms of outcomes from individual woman I from our longitudinal sample. For instance, let us consider modern contraceptive use, or MCPR for short. We indicate MCPR for woman I by the subscript I. And we can observe this woman's modern contraception at different points in time where we indicate the time point of observation with subscript T. For instance, suppose that MCPR is a binary variable that equals 1 if woman I is a user at time t and 0 otherwise. Well, with this data design, we can observe the trajectory of woman I's modern contraception use over time. Here we see a scenario under which she is initially a user of modern contraception at baseline before dropping it as of midterm, only to take it up again at end line. And clearly, there are all kinds of trajectories it can take over time. We particularly think of the URHI program as trying to encourage this possibility, whereby non-users become persistent users. Now, this graphical discussion has focused on the woman level, but we can aggregate across women, as in through an average. The overbar here is meant to represent an average. We can then look at average modern contraceptive use, or the modern contraceptive prevalence rate over time. We can track, for instance, whether and by how much it rose over the URHI era. This is sort of a monitoring exercise. And with our data, which included rich measurements of the background and characteristics of these women and their households, we can monitor for different types of women, which we generally represent by the characteristic X. To fix ideas, this could, for instance, be whether one is poor or non-poor. The trajectory of modern contraceptive prevalence rate for women who are poor and for women who are not poor. So that gives some sense of what we would capture in terms of characteristics and outcome for the women in our samples. But what about the programmatic end of things? This is, after all, an evaluation. Well, to begin with, let's think about the overall program exposure of woman I at time t, which we represent by P with hopefully now familiar IT subscript. The URHI was a multi-component program, but it's useful to broadly organize these into demand generation component, represented here by D. It was designed to get women to increase their demand for modern family planning. And a supply side component, represented by S, designed to improve the supply of family planning services. Let's start by trying to wrap ourselves around what we mean by demand generation. For instance, the various programs usually offered some kind of television-based messaging. We asked women about their recall of these sorts of messages. The TV with a bar over it represents the average rate of recall of TV-based URHI family planning messages, the overall prevalence of which we could then track over time. And we could track recall of TV messaging for population subgroups of women.
We have 46 people.
Such as the poor, and non-poor. Bringing together these outcomes and demand-side exposure, we could look, for example, at trends in modern contraceptive use among those who did not recall a URHI family planning message on TV and those who did recall seeing one. So we are looking at differences in trends in modern contraceptive prevalence between those exposed and not exposed to the TV-based program messaging as captured by their recall of those messages.
Just wear comfortable shoes, man.
Turning now to the supply side. Oh, pardon me one second. Turning now to the supply side, our usual approach was GIS driven. Suppose that woman I lived at the spot indicated by the green cross at time t. We then drew a radius around her place of residence that we felt suitably defined her local market. Now suppose that the red X indicated the location of the nearest facility with some URHI supply side component. If it's outside of the woman's market, we say that she was not exposed to this component. And if it is within it, we say that she was exposed to that supply side component. Now let's describe our impact model, which brings all of this together. We have modern contraception use, MCPR, of woman I at time t, and three factors that might shape it. First, her characteristics X at time t, her exposure to demand side factors D at time t, and her exposure to supply side factors S at time t. These influence her through a model along these lines. Of all the parameters this model, our particular interest is with phi D, which tells us how her modern contraceptive use responds to exposure to the demand side components, and phi S, which does the same for the supply side components. So what this model is telling us is that at time period 1, woman I's contraceptive use is being determined by this model. So her modern contraceptive use at time period 1 depends on her characteristics X at time period 1, her exposure, demand side exposure D as captured at time period 1, and her supply side exposure at time period 1. Note as well that her intercept, which is her expected contraceptive use after accounting for these three factors, depends on two parameters, beta 0 and beta 1, or at least it does in time period 1, as we will see. We also have unobserved determinants of modern contraceptive use, mu and epsilon. As you can see, epsilon takes on a particular value at time period 1. This is an unobserved determinant of modern contraception that varies over time. We also have an unobserved factor that influences modern contraception but does not change over time. Notice it does not have a T subscript, just an I subscript indicating just woman. It has the same value for woman I at all time periods. Suppose that this unobservable mu influences or is in some fashion associated with demand exposure D and or supply side exposure S. Now, by our model, it also influences modern CPR, and we cannot observe it. When we have a situation like this, it is very difficult to obtain correct estimates of phi D and phi S, the effects of demand and supply on modern CPR. To make this concrete, suppose that mu is motivation, an individual characteristic that is intrinsically difficult, if not impossible, to measure. If more motivated women are more likely to use contraception and recall exposure to, say, a demand-side programmatic message, then when we try to estimate the effect of exposure to that demand-side measure on modern contraception use, it would reflect both the effect of that demand-side measure on contraception, which is what we want, and reflect the fact that the exposed are more motivated. So in a sense, it's capturing two things. Demand-side exposure would be forced to play two roles, as a control for itself, which is what we want, and as a proxy for unobserved motivation. The latter role could crowd our estimate of phi D. So the problem is mu I. And what do we do about that? Well, we remember that we have longitudinal data. We observe woman I not only at the end-line time period t equals 1, but also at baseline, or time period 0, before the program was implemented. So we could just subtract. So now we would be modeling the change in modern CPR from baseline to end line, which we call delta MCPR. Continuing to the right side, we have the constant beta 0, which cancels out. Straightforward math, we are left with beta 1. Because basically beta 1, because t equals 0 at time period 0, so beta 1 times 0 is 0. Moving on to observed determinants, let us consider the subtraction for x. Now we have the change in x over time, or, borrowing the convention from the left-hand side of the equation, delta x. Similar math would leave us with delta d and delta s. But then, notice that something great happens. The term mu I subtracts out and is no longer in our model. The intuition here is that an unobservable that did not change over time could not explain changes in modern contraceptive use over time. However, epsilon, which does change over time, leaves us with the term delta epsilon. So this is our impact estimation model, which, as we have just shown, does not feature the persistent unobservable mu I. It is gone. Now, the impact results we report are basically the estimates of phi d and phi s. Since most of our measures of programmatic exposure are binary, as in either you were exposed or you weren't, and our outcome, by the way, is also binary, the interpretation of phi d and phi s is as a marginal effect. The marginal effect of a given program component tells you essentially the change in the probability of using modern contraception that would occur if a woman was to go from not being exposed, or from not being exposed to that program component to being exposed to it. In other words, it tells you the change in the probability of using modern contraception caused by exposure to that program component. All right, well, I think we've set the stage enough, and it's time to get down to some results. We begin our grand tour of the URHI countries in Nigeria. The URHI local implementing partner for which is NURI, or the Nigerian Urban Reproductive Health Initiative. The Nigeria program was implemented in 6 cities: Ilorin, Ibadan, Benin City, Abuja, Kaduna, and Zaria. Intervention was delayed somewhat in Zaria and Benin City. The NURI strategic approach involved integrated supply and demand, consumer-first programming, incentivizing supply to meet demand, and finally, advocacy. We had pretty big sample sizes across the cities. This gave us more power to detect impact, and this is something that we're going to discuss at the very end of the lessons learned section. But these are pretty big city-level sample sizes with a fairly large overall sample size. As you can see, attrition from baseline to end line was something of a challenge. We also interviewed all sorts of facilities, and in the context of the cities, these were fairly large samples from the providers of these strata. We ended up with a sample with quite a few facilities: 132 NURI facilities, 253 non-NURI facilities, 433 pharmacies, and private medical services, 540. So to set the stage, let's consider the patterns of family planning use at baseline and at end line. So here they are across each of the cities of our Nigeria study cities. First, modern family planning use rose essentially everywhere, typically in the 10 to 15 percentage point range, with generally less increase in cities that had higher use to begin with. In terms of dynamics, most simply remained non-users or traditional users over time, about 58% that was true of. But a solid 20.8% took up modern use over time, and 11% continued it. Unfortunately, the continuation of modern use was just about offset by the discontinuation of modern use between baseline and end line. So let's get to impact. To set the stage, we'll talk a bit about exposure to programmatic components, or at least some specific programmatic components that we're going to consider today for Nigeria. In terms of patterns of program exposure, there was fairly wide exposure to TV and radio programs, with about 60% having seen a family planning message from NURI on TV, and about 75% having seen one on the radio. There was somewhat lower exposure to NURI community outreach efforts at about 33%. Exposure levels for NURI print media and provider badges were in the same basic neighborhood as outreach, with 38% for print media and 26% having recalled seeing the NURI provider badge. Turning to the supply side, we have a range of exposure rates for the components that we considered for the supply side. In all cases, we considered a woman to be exposed if she lived within a kilometer of a facility that had a given supply side program component. These included IEC and outreach programs, and finally, whether the facility was actually a NURI facility. And here are the impact results. In general, there was a large impact to radio, community outreach, the provider badge, and having a NURI health facility within 1 kilometer. So, for example, the marginal effect of NURI radio was to increase modern contraceptive use by 4.28 percentage points. And by the way, highly significantly statistically increase it. So if you went from not recalling a NURI radio program to recalling it, your probability of using modern contraception increased 4.28 percentage points. So these are pretty solid impact numbers, and I think it's a real tribute to the hard work and careful planning of the NURI program that we see this range of strong and generally statistically significant impact estimates. Well done. The next stop is Kenya, where the local implementing partner for URHI was the Kenya Urban Reproductive Health Initiative. In Kenya, the study cities were Kakamega, Kisumu, Nairobi, Machakos, and Mombasa. Intervention was delayed in Machakos and Kakamega. In Kenya, the strategic approach centered on access and quality of long-acting and permanent methods, access to, I should say, and quality of long-acting and permanent methods, commodity security, youth-specific programming, and promoting family planning as a social norm. The sample sizes were again large, and the idea once again was to allow us to have some good power to detect impact. So these are pretty big city-level samples, and you can see that in some sense we stratified because there's, well, I shouldn't say that. Nairobi has the largest population. Nairobi has a larger sample size than the other cities. However, as with Nigeria, attrition was something of a challenge. Now, in terms of patterns of family planning use, there were increases from baseline to endline, with some evidence of smaller gains in cities with higher baseline modern contraception prevalence to begin with. But as you can see here, you're generally talking about a 10 to 15% increase by and large across the cities, with some particularly large gains such as the 15% you see in Mombasa occurring. In terms of dynamics, substantial numbers took up or continued modern method use. So 23.6% adopted a modern method and 29% continued it. 35%, 35.2% continued non-use or traditional use, and a 12% discontinued. Now let's talk about the evaluation. So once again, we're going to look at some select program components, and I just have to say that of all the graphics we've used in our slides for our presentations over the years, this one might be one of my absolute personal favorites. I don't know why, but I find it mesmerizing. So, 13% reported discussing family planning with a community health worker, while 7% reported having heard the program, the Kenya program's Jungle Love radio program. Turning to the supply side, nearly half reported seeing a Tupange facility. So Tupange was the program's sort of local name. So about 46% reported they'd ever heard or seen an Umua Tupange branded facility. And if you look at this facility, you'll see at the top on the right there's a blue cross. In the middle it says Mari Stopes, and then on the left you see the Tupange branding. While almost 70% had a Tupange strategic health facility within 1.5 kilometers of their residence. So turning to some of the significant impact results, we see that radio programming had a large and significant impact on modern contraception use, followed by a community health worker, and lesser amounts for the supply side variables. But still, taken as a whole, when you think about it, very, very solid impact numbers here in Kenya again. Turning to Senegal, the local implementing partner was the Senegal Urban Reproductive Health Initiative, or, in my butchering of the local French, the Initiative Sénégalaise de Santé Urbaine. I'm going to often refer to it by the French acronym ISSU, or ISSU. I always call it ISSU. The study cities were largely concentrated in the western, more central coastal areas of the cities, of the country, excuse me. They were Dakar, Kine, Gideaway, Mbao, Boer, and Kaolack. Boer and Kaolack were the delayed intervention cities in Senegal. Now, in terms of strategic focus, the Senegal program focused on commodity security through something they called the push model, integration of, well, with particular emphasis on something they called the push model, integration of services, addressing staff shortages, and engaging religious and community leaders. Once again, the sample sizes at baseline were large and with the same objective. We wanted to be able to have a lot of power to detect impact. Attrition, while it was an issue in Senegal, it was not nearly as pronounced as in Nigeria or Kenya. We had a better experience tracking and finding women at follow-up in Senegal. In terms of patterns of family planning use, we once again see a familiar and positive pattern of increased modern contraception use in the cities. This time there's less of a clear relationship with additional modern contraception prevalence in a given city. As we can see, in terms of dynamic changes, the biggest action was those who simply remain non-users or traditional users from baseline to end line. That was almost 70% of folks. About 15% adopted a modern method, 8% continued, but that was canceled out by an 8% that discontinued a modern method. Turning once again to impact results. We'll once again focus on some specific program elements, components. To begin with, on the demand side, about 20% recalled ever hearing an ISU radio program. 58% reported hearing a religious leader speak favorably about family planning, a major focus of the program. 28% had ever heard a family planning message at a community event or from a community health worker. Turning to the supply side, 96% lived within 1 kilometer of a facility with the push model. So of these program components, the runaway winner was exposure to community-based activities, which increased the probability of modern contraception use by nearly 6 percentage points. But however, you see also fairly large, but unfortunately not statistically significant result for general radio. The negative result is not significant, so I would not, it's highly insignificant, so I would, for push, so I wouldn't focus very much on that. I'd probably consider that about a wash. Finally, we turn to India, where the local implementing partner's UHI program was known as the Urban Health Initiative, or UHI. The India study cities were confined to the state of Uttar Pradesh. However, within that state, the study cities were pretty evenly spread out. They were Moradabad, Aligarh, Agra, Gorakhpur, Allahabad, and Varanasi. Intervention was delayed in Moradabad and Varanasi. The strategic focuses for the Urban Health Initiative included client outreach and community mobilization, postpartum family planning, quality and expanded service delivery, and communication and counseling materials. One way in which the India experience differed from the African evaluations in general, and particularly those in Nigeria and Kenya, was a pretty low rate of attrition. Once again, however, you see that we started out with very large numbers of eligible women, women interviewed in the study cities at baseline because we wanted to have a lot of power to detect impact, once again. Now, in terms of patterns of family planning use, we once again see increases in modern contraceptive use in each city. The increases generally are a bit more modest than what we saw in the African setting. In terms of dynamics, the dominant category at nearly 40% was continued use of modern methods, followed closely by continued non-use or traditional use, and more distantly at 15%, adoption of a modern method between baseline and end line. In terms of our impact evaluation results, exposure to UHI or to UHI TV spots was at about 62%. Exposure to their spots on the radio was much lower at 2.7%. Recall of interaction with a UHI community health worker was at about 16.5%, while 3.8% had recall of their mid-media efforts. Poster, wall painting, billboard, etc., that was about 79.2%, very high recall. Recall of a brochure came in closer to 24.2%. Now, in terms of the supply side, the percentage of women living within a certain distance of a UHI facility at Endline was, so within 1 kilometer, we have about 30% living within 1 kilometer of a UHI full implementation public facility. And we have about 57% living within 1.75 kilometers of a UHI full implementation private facility. In terms of the impact results, the brochure is the runaway winner here with an extremely solid 7 percentage point increase in modern contraceptive use that comes from going from not recalling to recalling the brochure. And generally speaking, though, as with every one of the countries, when you consider what you usually see in impact evaluation, these are fairly solid results overall across the board. So the summary across all countries, basically community events were a big winner. The supply side was pretty solid. In Nigeria and Kenya and Senegal, Senegal, I didn't show it, but it also was for men. Mass media did really well. Radio, TV did really well in Nigeria and Senegal. And I think a sort of overarching feeling that we have after having conducted all of these impact evaluations is that you really need multi-component, integrated, comprehensive programs in the urban setting. So we've discussed our impact evaluation results, or we've at least given you a few results to get some sort of a feel for this. So having discussed our impact evaluation methods and a few results, we're going to conclude by offering some lessons of the MLE experience to inform future evaluations. These lessons might seem simple and basic and have a well-duh kind of quality, but the biggest and most important mistakes we often make in life are very basic ones. I'm almost reminded of a phrase from a Dave Eggers novel, where he referred to the mistakes we knew we were making. Now, the MLE project did get many things right, but it didn't get everything right, or everything didn't always go according to plan. Either way, whether it went right or we had to fix things, looking back you get a clearer sense of the big and defining challenges. First of all, getting a project like this up and running will be hard. It will be so much harder than you think it will be at the very beginning. There's so many things you have to do. All of them are incredibly involved. They involve a great deal of work, thinking, and planning. An extremely abbreviated list includes selecting local partners, negotiation of contracts and operational arrangements, creating comparable instruments across very different settings, engaging multiple stakeholders, multiple institutional review boards, multiple national statistical offices. Remember, your sampling frame has to come from somewhere. The program will not get going as fast as you think or they claim. And you'll need to ride some bumps as they make adjustments to their program. That might require adjustments to your design. There is a kind of curse of dimensionality to doing this in a multi-country setting. 2 countries are not twice as hard as 1 country. 2 countries are much more than twice as hard as 1 country. All of these things start to add up. And it's really, really important that you not allow them to distract you from the larger technical picture. And your work on that larger technical picture is how the project will be assessed in the long run. A big part of not allowing that distraction to happen is planning for these startup things to take a lot of time and effort. Don't plan for this to be easy. Plan for it to be hard. The baseline instrument and the sampling are just so crucial. The most powerful possibility that panel data affords is methods such as fixed effects, which we used, that require repeated measures. You have to measure the same thing about the same people at baseline and follow-up. So you have to think really hard about what you're capturing in the baseline instrument, because that baseline instrument is locking you into what you can do at baseline, both in terms of what you can, locking you in at baseline, and both in terms of what you can measure and how you can estimate impact. You're really designing an instrument for many surveys when you have a longitudinal study, and the attention to detail should be commensurate with that consideration. A poorly thought out instrument will haunt you for years. We invested a lot in our instruments, and I think it really paid off. It's inevitable that you're going to have some things where you say, oh God, I wish we asked this at baseline, or I wish we asked that, or I wish we hadn't put it that way. That's inevitable, and it happened to us too. But I think that careful design mitigated those issues, and that's really important. Put a lot into your baseline instrument. I'm a sampler, as Rebecca explained in my introduction. I think that sampling should be conservative always, but I think it's doubly so in a project like this. All of the things being equal, smaller samples can only detect larger impacts and differences over time with acceptable precision. So if you want to detect impact in the kind of ranges that you're likely to see for programs like this, you need large sample sizes. Attempts to save resources by limiting baseline sample size are really just robbing your future self. Attrition is going to mount. The desired degree of impact will likely tighten as the program proceeds. Everyone has very wild ambitions in the beginning. More and more elaborate questions involving smaller and smaller portions of the sample are likely to arise. They're likely to want to know to inform future programming. You're going to need a much bigger sample size than the minimalist argument for baseline suggests. To use an American expression, when it comes to sampling for something like this at baseline, go big or go home. You need to put good systems in place. In a big multi-country survey agenda like this, you have a lot going on. You have a lot of people doing all kinds of work and all kinds of stuff with many, many files, including data files, in a very intense environment where deadlines seem to always be looming. You need to have good operational systems and procedures to avoid chaos. This is one area where admittedly we did not do as well, and the result was a lot of frustration, confusion, and deadweight time lost before we designed and implemented the far simpler, more organized, effective system we have now. I mean, positive thing for us is we recognized the problem and we learned, but we didn't have strong enough systems in the beginning. Strong enough systems for things like tracking of files, stuff like that. A major lesson of this is that there needs to be a very limited, or a major lesson of our experience, excuse me, is that there needs to be a very limited number of people who are the stewards of really critical files, such as certain data files for system purposes, certain administrative files. You have to really have limited stewardship of key files so that you can have real version control. You have to have the right team. Implementing this requires so many people. You need samplers like me. You need statistical programmers, also like me. You need data processors like my colleague Amy, sitting behind me right now. I cannot begin to describe to you how difficult it might be to find data processors. This is an area in our industry where we have critical manpower shortages. Sampling too. You're going to need GIS professionals. You're going to need people who are good at data management, which is almost as much a personality type as a skill set. I mean, it requires a great deal of skill, but it also requires a certain exacting kind of personality. You're going to have people that are experts in contracting, all the other aspects of administration. You have to think hard about and anticipate staffing needs, since a need can go from non-existent to urgent almost overnight. You need to think hard about who needs to be at the table for each decision, and it doesn't hurt to ask folks, do you think you need to be at the table for this decision? Ignoring a critical technical perspective for a key decision can haunt you for years. At the same time, you need to think about who needs to be in the room because you need to avoid cacophony. If you don't have enough cooks at the pot, it won't be a very good soup. If you have too many, it will be a disaster. So you need to, and part of making all of this work is you need to invest a lot in team cohesion and create a solutions-oriented culture across these different disciplines. This is a big one. I think this is one that not only we've experienced, other longitudinal surveys like the China Health and Nutrition Survey, the Russian Longitudinal Monitoring Survey, the various RAND Family Life Surveys have all experienced. Maintaining a longitudinal cohort is a big commitment. I have been on a couple of longitudinal efforts since then, and at the beginning there's always this argument that will be different. It will be easier here because ... No, it won't. Maintaining a longitudinal component of a cohort is hard. It doesn't matter where you're operating, and you should go into it thinking that. It's going to require a lot of resources. It's going to require a lot of careful planning. A well-designed tracking module is essential for all panels except the end line. The actual tracking procedures that follow up require a lot of thought, and what will be successful will be context specific. So the fact that something worked in one place does not mean that it will work in another. In India, where many women had moved by midterm and endline, we had a very centralized paper trail-driven system for tracking women who had moved from their previous cluster of interview. it worked well. This approach failed miserably on a tracking pre-test in Nigeria, and the eventual protocol there gave a lot more initiative for tracking to the local tracking teams in the clusters. In Kenya, we ended up actually giving the field teams a full packet for each woman, and basically, in essence, completely decentralizing the process. Now, you'll notice that I mentioned a pre-test. It's very, very important to pre-test your tracking procedures as you would your survey procedures. Finally, and remember, this was an impact evaluation. That was our objective. Never bet the farm on one impact evaluation method. Events simply might not cooperate with you in terms of making it feasible or credible. You have instruments that might pan out, might not pan out. You have variation you thought you were going to have due to initial discussions of the program that might not emerge. So you might have to think a lot more creatively, for example, about the counterfactual. If you think about this as an airplane, don't take off without some econometric parachutes in the plane. Pursue designs that could, in principle, accommodate multiple impact estimation strategies. Because for any given question that you want to answer, for which you want to answer impact or provide impact, you might be in a situation where if you had 4 methods, 3 out of the 4 didn't work out and everything rested on the 4th. You need to plan for the best laid plans of mice and men not to work out. Okay, well, that brings us sort of to the end of our webinar today. It's been a long webinar, about 40 minutes. I think that's longer than a normal webinar. And I really want to thank you for joining me and putting up with my voice for 40 minutes. And I'm going to turn the floor over to Rebecca at this point because I think that we probably have questions, or I don't know. Rebecca?
So we just have one question right now. And if anybody has any other questions, please just type them in the chat box. So the one question we have is data available by method type as well?
Yes. Yeah, Lisa, yes.
Yeah.
Yes. Yeah. We like our modern use variable actually is based on decisions about which of the methods in each country we consider to be modern methods, and we sort of a person was deemed a modern method user if they were using one of those methods. So yes, in fact, our modern method variable comes from those individual method variables.
Okay, and we have some more questions now.
Okay.
Was MLE able to sample in the informal settlements of the cities?
In places like Senegal, and the answer to that question is yes. Our sampling frames either explicitly included a domain for this, or they were frames of the entire city, hence would capture the informal settlements. In India, we actually ended up oversampling folks that were in informal, slums, informal settlements, tenure insecure settlements, whatever you want to call them. We actually did an exercise to map them, and that provided us with a slum strata. In Senegal, we have the ability to stratify based on the official frame, which captures such settlements. But in all cases, our frames of the cities were area frames, which are mutually exclusive and exhaustive, which capture the spatial area of the cities in a mutually exclusive and exhaustive fashion. So it would capture anything within it, including the informal settlements. And yeah, I mean, Lisa's been in the field a bunch of times. Lisa, we went to informal settlements a bunch.
Yeah, I mean, as Peter said, in India in particular, we intentionally oversampled the slums, and so we're definitely in the slum areas and in the impoverished areas of all of the countries that we worked in. So. Okay,
next question. Oh, and by the way, if you don't like our answer, you can resubmit the follow-up. So this is America. You can do what you want. Go ahead, Rebecca.
Was any of the data collection done digitally using mobile data collection tools or cell phones?
The answer to that question is no. That's something that I think on some that we're probably going to increasingly push into as time goes by. But a frank assessment of that at the time of baseline suggested that maybe that wasn't the wisest way to go. When you think about using these technologies, there's a lot of things to consider, and I think, for example, one of them was, for us, is data confidentiality. and the security of our data against the practicality of being able to use these things in the field. The other thing is, at the time of our baselines, there wasn't as much of a settled technology for this, I would say. And that was really, so there was the possibility that it would be locked into a technology that then didn't sort of become a standard for this sort of data collection. Amy, you have something you want to say about that?
Yeah.
Amy's our data processor, our expert on such things.
I think, there's been a big push, especially of late, to rush into the CAPI environment in the developing context because you now have the technology and the software to be able to do that. But I would offer the huge caveat that, again, you need to place a lot of time and effort on the procedures of how you are going to manage that data collection effort in the field. I have seen data that have been collected using a tablet that did not have strong controls and checks and balances across multiple instruments, and the result is that the data sometimes become almost unusable. So you really have to think about how you are going to maintain the data quality and the data integrity, and whether there is actually the local capacity to be able to implement and also support such an effort.
Okay, I think we buried the lead on that one. Rebecca, what's our next question?
How were gender considerations incorporated into any of the interventions?
How were gender considered? You know something, if the question is how were they integrated into the programs themselves, I think it's probably wisest for us to defer to them to answer that question.
Yeah, I mean, I can try to say a little bit, but we're not the program. I know specifically in India, they did a lot, or one of their efforts was working with men, and so they would go to rickshaw wallers to promote use of male sterilization. In Senegal, there were specific activities working with men and religious groups. So I think it depended on the country context. I mean, that's male specific. They did try to work with women's groups. It was a consideration, but I think the best bet would be to look at some of the websites for the programs to learn a little bit more detail about what their specific activities were.
By the way, on the level of our stuff, though, the surveys, we actually, I think gender was an extremely important component. We actually had, like, for example, I mean, the focus this is because it's about raising modern contraception, and we're approaching it through the actual data framework through kind of like I hate to say it's like a DHS type of lens. Mm-hmm. The focus was going to be on women of reproductive age, but we also had things like specific questionnaires for men too. So that was definitely a factor on our side of things, not the program side, but MLE's side of things.
Right, and our questionnaires do have a lot of similarities to DHS style questionnaires. So we have questions on domestic violence, mobility, decision making, kind of those general women's empowerment questions. And when we did do men's surveys, we asked similar questions in those surveys as well. So we can kind of take a deeper look at some of those issues with our data.
Next question.
Can you talk more about the supply side and the role of product availability? I know that's...
Can we talk more about the supply side and the role of product availability? Well, I mean, the supply side mattered in this. Let me flip back. I'm going to flip back up to the... let me see. Let me go back to, for example, India. I'm going back now. Where are you? Here you are.
I mean, so we do have stockouts and method availability questions in all of our facility audits. And so though that information is not presented here, that's something we can look at. And we have looked at a little bit, but it's not included in our impact evaluation models.
Yeah, I think, one of the things about impact evaluation models you have to be careful about is there's this trade-off because you want to be able to get a very comprehensive, detailed look at the situation, But when you over-specify these models, the problem is that a lot of these program components were, if it was done somewhere, if one component was done, all of them were done, is a problem you often run into. And that introduces a relatively serious estimation problem called multicollinearity. And so it's always a little bit of a trade-off between having the most detailed, granular, comprehensive sort of thing and having good estimates. And the thing is, there's not really a way to overcome that because the multicollinearity simply reflects the reality of the way the program operated.
But it's true that having methods available is a key component of most of these programs, whether it be the Senegal push model, where they, the whole idea of that was that they kept sending methods out to facilities whether or not they essentially needed them. In Kenya, they developed a very specific commodity management and redistribution system to make sure methods were available at facilities. I'm trying to think of what they did in Nigeria. I guess those are two examples, but all of the countries did have a focus on making sure methods were available.
Other questions?
Was any of the data fed back to local partners to help them improve their future FP efforts?
So we have 3 surveys: baseline, midterm, and endline. And so after the baseline survey, the programs all use that information to help inform their programming and discussed it with local stakeholders. At midterm, the data was actually used and reviewed, and we looked at it as many different ways as possible to help make programmatic modifications moving forward, to help them figure out early on what's working, what's not working, what needed to be tweaked.
Mid-course corrections.
Yeah, the mid-course corrections. And again, that involved meeting with government and local stakeholders as well as the programmatic people. And then currently, the information from our evaluation is actually being used for this, another Gates Foundation funded initiative called the Challenge Initiative, where they're actually taking the successful program elements from these 4 countries, scaling them up to other interested cities, either within the same countries or within the general region, although there needs to be kind of local funding and buy-in to do these things with TA provided by the URHI teams.
Thanks, Lisa. Was there, do we ask questions about emergency contraceptive use or included in modern methods?
Yeah, emergency contraception was, so we did measure that. We had, our contraceptive use questions were essentially the standard DHS type questions. And so we did capture that. We can break that out, and that, yes, it was included as a modern method.
Yeah, the answer is yes.
Okay. It asked if results were disaggregated by age. I know that they were, but it asked the type of impact on young users, 10 to 19 years old, especially in Kenya where youth programming was included.
We did do some degree of efforts at looking at this. However, this is another problem with impact evaluation. And remember, stepping back here, compared to most evaluations of this nature, our sample sizes are enormous. And so what is true of us is going to be doubly so of others. You need a lot of sample size to have the power to detect impact of, like, say, modest amounts. And so when you start getting down to these finer and finer population subgroups, you're getting down to smaller and smaller sample sizes. And so if you don't detect impact, it becomes really difficult to tell what's going on here. Is there no impact, or do you just not have the power to get it? And so while we did do some of this, I think there's a reason we sort of highlight these sort of top-line results that you see like today, because those are the highest power results. So we did try a bit, but again, it's like the problem of adding a lot of program components, and as you start running into these statistical issues that are just inexorable. Other questions? Rebecca?
Sorry, I was on mute. Was there any follow-up activity, or was there any qualitative follow-up on what people liked about the various demand generation activities?
No.
No.
Okay, that was quick. Were there any discussions with local partners after the intervention was over as to how they could use data on their own for FP efforts.
Yeah. Well, sure, kind of. Yeah, I mean, we work with them. I mean, it's a very working relationship, and so yeah, there's a constant process of that.
There is a constant process, and I guess this is a good opportunity to plug the fact that we've made our data available to people that are interested in it. And so if you go to our website, you can actually request the data. And so
the link for what you see at the bottom of this page.
And so we have a lot of interested parties, and we are collaborating with a lot of people to help them with the data as well, because it is a little bit complicated given the longitudinal nature of the data.
I mean, the answer is yes, but it's come to extend well beyond even the local implementing partners. It's really become a global collaboration because, like I said at the beginning, this was partly a laboratory. I think the Gates Foundation, and to very much their credit, saw this as a laboratory for learning. So it's really it's a global public good.
Okay. In the interest of time, I'm just going to do one more question.
Okay.
And then the rest of the questions we'll send answers to the list so everybody can have an answer to their question. So are you able to comment if method availability was more important than client education?
Not really. We could probably squeeze another question in now.
Okay. Sorry, I wasn't ready to ask you another question. Can you please repeat the reason for high attrition in Nigeria and Kenya?
The reason is because it's really hard to track people. I mean, honestly, I know that sounds like a very circular answer, but that's the truth. We had elaborate tracking procedures in place. In general, tracking was going to be a very difficult thing from the beginning because these are very, very dynamic settings in very, very dynamic societies. There's constant turnover of who is living where. You have circular migration, you have urban to rural, or rural to urban migration, you have urban to urban migration, you have tremendous moving around within the cities. And it partly comes down to the cultural institutional setting of these countries. There are some, like it might matter in a country how often people keep the SIM on their cell phone, which is partly a cultural thing that varies from country to country. Or it might be due to the fact that maybe the cell phone market was opened up in one country or another. I mean, it comes down to little things like that. And so, basically the reason is because it was hard to track them, because the circumstances there meant that a lot of the things that we and others have traditionally used in tracking did not necessarily pan out. But when I said that it's context specific, I didn't just mean a place, but also a time. If we were to redo this starting from now, who knows? Now things have changed. Maybe in Senegal it would be hard to track people, in Nigeria where it would be easy. You just don't know.
Yeah, well, and to add a little bit to that, I think one of the big differences is that in India, our sample, and I don't think this actually came out in Peter's presentation, the sample was all currently married women. And so these women are already, they're married, they're, living, they're kind of grounded in their situation. And so we were the most successful in India. And then a country like Kenya, it's a highly mobile urban population, as Peter said. And as an example of that, of the women that we found, over 50% of them had actually moved. And so people are moving all over the place. And, of those that we didn't find, it's because they had also moved. And so the phone number issue, this is maybe too detailed, but in Kenya, along the lines of what Peter said, they changed their registration process for SIM cards in the middle, in the middle of our survey stretch, and so that means people went from not really registering SIM cards to registering them. So everyone changed their phone numbers. So all of this detailed follow-up contact information that we had changed for people.
And let me give you an example of how this kind of a time dimension, because not on this project, but on something else I'm doing right now, we were just talking about the arrival of smartphones in Africa. I think of first generation small cell phones. There's a technical term for them that eludes me this morning. I've only had about 8 cups of coffee, forgive me, but I'll call them dumb phones. Basically, there's a transition going on right now from dumb phones to smartphones. So if you went into a country and started your baseline now and that was happening in that country, there's going to be unbelievable turnover in numbers and SIMs, and that's going to undercut this as a tool for tracking, whereas in 5 years the situation might be much more subtle. I mean, I've had the same cell phone number for, 10 years now, and I keep changing my cell phone all the time. So but before that, I actually changed my number a bunch of times. And so the thing is, it really depends on the context. I think the United States, for example, would become much more settled in this regard. So it's not just a place. And again, don't overgeneralize about what will happen if you go to these 3 African countries in India in your study. It's not just a place, it's a time. You have to think very carefully about what's going on there.
Yeah, we actually found that the most valuable information we got to find women that had moved was from neighbors and people in the community. That even though we had collected, 6 cell phone numbers at the baseline survey, different ways to contact the respondent, that the best method ended up being someone that knew her personally and said, oh, she changed her phone number, or they moved just down the street, or, that kind of, that community information.
Which brings up another good point. Your tracking procedures should allow you to exploit other people aside from just your respondent, because I mean, it should allow you to have some ability to find other people that can help you track. Now, it was the IRB you said? Lisa was saying, IRB, as I said this, and you're right, you need to run this past the IRB. But the richest tracking module possible is a good idea in light of the fact that things change, and something that worked once, even in one setting, might not in the future. Rebecca, is that it?
Yeah, so we're a little over time, so I'm going to thank all of you at UNC for your great presentation and insight, and also all the questions and our participants, and everybody have a good day. Thanks.
Thank you for your time today, guys. All right, bye-bye.